Thank you. You've said everything. I don't need to say anything. I think we have very capable people here who can take it from here. And I'm grateful to everyone who's taken part and all the people who are joining us here. And I'm sure we'll continue to have lots of these webinars in future as well for all our young audience. And thank you, Nikolai, Giovanni, obviously owner, and all my dear friends. Mirza is there as well. Oh, I see Greg Trost as well. How are you, Prof? Good to see you. Long time no see. So I think we have a great company today. So thank you for everything. So guys, you can carry on. All yours.
Yeah.
Yes, Nikolai, do I have to start?
Yes, please. I think it's we are 2 minutes late now, so we have to start 2 minutes ago.
Is Abdel here?
Yes.
Yes. So our topic is innovation in spine surgery, and this is your turn, Abdel. Robotics current and future. Please start.
Perfect. You see my screen now?
Yes, perfect.
Well, first of all, thank you so much to the WFNS for the very nice invitation. I hope that maybe next year we have the conference in person, so we're not on these webinars. Beginning here. So today I'm going to be talking about robotics and spine surgery, current and future applications. These are my disclosures. Just for the people that are in the United States, I just need to say that I will be discussing some off-label applications, so just keep that in mind. So today the objectives, I would like to talk about the current capabilities of robotics and spine surgery, and then give you a glimpse about what we think the future of robotics and spine surgery is going to be. So before we start, we need to realize that we're in a really unique time in our technology and civilization. Moore's law says that the rate of adding transistors onto a chip doubles every 2 years. That was 20 years ago. Now the rate of doubling transistors can almost be every day. And so similarly, the rate of technological advancements in all areas of science really is exploding. And so, we can take two different attitudes to technology. We can take an adversarial type of stance. Here is Gary Kasparov in 1997 playing against the IBM machine. And he says that, when he was playing in 1997, he felt that the whole, weight of humanity was on his shoulders. And he felt that he was, being the last bastion of, man versus machine. If we compare that to 20 years later and his attitude, he's changed his attitude completely. He realizes that machines and robots have a place, and we really need to realize what their place is. So machines have calculations, we have understanding, they have instructions, we have purpose, we have passion, they have objectivity. And so if we keep that in mind, then we can actually use machines and use robotics to our advantage. If we look at, just the interest in robotics and spine surgery, you can see there's an exponential growth in publications about robotics and spine surgery. So right now, we're in this area right here. We're in the early adopters. So there's now more and more people using robotics and spine surgery. And it's not clear yet whether we're going to cross this chasm that always happens when there's a new technology. If we combine this and we look at what we call the new technology hype cycle. So there's always a time where we have first generation products. They are very expensive. So the average robot sometimes will cost over $1 million. And there's a little bit of hype and lots of people are buying it. And then some things happen that we realize, hey, maybe it's not as good as originally planned. And so then there's kind of a dip. And if we look at, when we compare that to the kind of hype cycle with this chasm, we can say that how low this disillusionment happens is going to really determine whether we cross that chasm of adaptation. So if we really look at how robotics are today, if you look at the definition of a robot should be something that replicates human characteristics and human movements. And so really the current iteration of robots in spine surgery really is not a robot. It actually is a cobot, where a computer is allowing the human to do something that they would like to do. So if we look at what we would consider an ideal navigation or imaging system, we'd want something to have real-time imaging. As we are adding instrumentation, as we are doing osteotomies, the anatomy is changing. And so we need to be able to keep that in mind. It would be really good if we could have no need for fixation on the patient. It would really be good if we could have no preoperative scans or CT. We should be able to recalibrate easily. As we are doing more and more minimally invasive surgery, we've realized that radiation is important. So we want to decrease our radiation and hopefully not increase our OR time. So right now in the current iteration, robots are just an expensive drill guide. The robots right now, the only FDA approved application is that they help you determine the ideal trajectory, but still the surgeon must place the screw. Just so for people that aren't used to it, here's a little video. So this is one of our residents here. You can see here that the robot has gone to a certain trajectory that we've done through either a pre-op or intraoperative CT. And basically it's a drill guide, but still the resident has to put the drill through it. So here you see So currently, that's all that the robot is, in the United States at least, approved for. So if we look at it, robots, I think, are going to be more amenable for minimally invasive surgery, because we know when we're doing open surgery, there are a lot of tactile feedback that we use just as we trained a surgeon. So we have to do a subperiosteal dissection. We have two forces. We have a dissection force going from medial to lateral. And then we have a screw force, which is going from lateral to medial. And you'd be surprised, as a human, you learn that very quickly. You learn to balance those forces. That's a little bit harder for the robot currently because there is no real haptic feedback that goes on. Current situations, they will be able to tell you, the skiving force and so on. But you'd be surprised that the human actually learns how to do that much faster than the robot. However, when we do minimally invasive surgery, when we're doing, let's say, percutaneous screws, that's a straight line trajectory. And so that's very simple for the robot to do. You tell them the trajectory and they can kind of lead you into that trajectory. There's not a lot of forces that are at play. So if we look at, how the robot is helping for people that are in academic institutions, it does seem that the robot makes the learning curve a little bit flatter. So if you look at how long it takes for a PGI-1 to put in a screw versus a more advanced resident, they're about the same. So there's not that great difference in learning curve. If we look at recent meta-analysis about the robots versus freehand or fluoroscopy, it does help with accuracy. So it does show that the robots will place more accurate screws. It will decrease the radiation to the surgeon and the OR staff. However, we need to also say that they do require a preoperative or intraoperative CT. And if you look at very carefully, at least at the beginning, the robots did seem to increase operative time. But as we get better and better and our learning curves gets better and better, I do think that they will decrease their surgical time. So if we look at our ideal imaging or navigation system, we can say that unfortunately, the robotic systems as they're currently done, they don't have real-time imaging. They do need some type of fixation on the table or the patient. You do need a preoperative CT, and they really don't recalibrate easily. So right now, there's still a lot of work to be done. It does seem that it does decrease radiation, at least to the surgeon. And right now, it's probably 50-50 whether it increases or decreases your OR time. So one thing that we've been very interested in is, can we use the robot for other applications rather than just the placement of pedicle screws? So we're going to talk about, different applications. And if we look at, what the robot can do, the robot can send you to a pre-planned area, and that can be a deep structure and can get you there pretty easily. So one application that we've done is using it for what's called a percutaneous T-lift, an entrance into Camden's triangle. So this is a case, a 64-year-old with back and leg pain. He actually refused general anesthesia. You can see here, he's got a grade 2 spondy when he stands. And so he's got an L5-S1 spondylolisthesis. And so what we did is we used the robotic software, not just to plan the screws, but we kind of hijacked the system to do a percutaneous entrance into Camden's triangle. So we used the current robotic software to do that. And you can see here, we gave him a spinal epidural. And then we did this actually with the patient awake. You can see here, we put in the screws with the robot, and then using the drill guide of the robot, it led us into Camden's triangle. And then we did a interbody there. You can see that. And you can see that we were able to do the surgery with less than 50 cc blood. This is the blood loss after the surgery. Operative time was 2 hours. Patient was able to go home the next day. So this really set out our enthusiasm for using the robot for other applications. We've published a case report, and now we actually have a case series of these percutaneous entrance into Camden's triangle. And it's really been very helpful for this application. You can see here, 4 of these cases were done with the patients awake. And you can see the Camden's triangle was very small. It's only 50 millimeters in 2 dimensions. But with the robot's ability to target certain structures, we're really able to do that very safely. You can see here that some of our patients are going home even the same day. Another application that we found very helpful is in using it for percutaneous iliac fixation. So, I work in a large academic center, and we see people with very large tumors sometimes. So this is a 48-year-old with invasive colorectal carcinoma. You can see here that this tumor has invaded his sacral area. He also had sacral insufficiency fractures. And, this is a very difficult situation. In this situation, if you're going to do a lumbar to iliac fixation, using S2 AI screw, as a lot of people do, is not an option because the sacrum really doesn't allow you to have a good starting point. So what we did is we actually were able to plan out all the screws beneath the skin, and then we're able to do the iliac screws so that there's no need for a side connector. And so that's one of the difficulties when you're doing iliac fixation, is that sometimes you need to do a side connector. So we were able to do this completely percutaneous. You can see here, all the screws are lining up. And so we're able to just do percutaneous screws at all the different levels. We always check, make sure that you've got your teardrop view. And here we're able to do this L3 to iliac fixation, completely percutaneous. We were able to send him home the next day, which is really important because this patient, ended up, having his ultimate demise very soon afterwards. And so we did not spend a lot of time with him being in the hospital and so on. We let him have a good quality of life in his last days. Another really good application that we found for the robot is putting in single position lateral percutaneous screws. So here's another patient, 68-year-old gentleman with lots of back pain. You can see here he's got degenerative disc disease at L3-4, L4-5, L5-S1. You can look at his vascular anatomy. He would be a good candidate for a lateral ALIF here, a lateral at 4-5, and a lateral at 3-4. And so instead of doing, 3 positions where you do a supine ALIF, then a lateral at 3-4 and 4-5, and then screws, We're able to do this all in one position. So we do a lateral A-lift. Here are his parameters here, where we have the patient on his left side. We do a lateral A-lift at L5S1. We do 2 levels of laterals with the patient in that same position. And then we're able to put in the screws with that patient in that same position. That is extremely difficult for you to do with navigation or freehand or fluoro. There are some surgeons that do it, but it is incredibly difficult. We found it, a lot easier now because of this drill guide to have the robot then help us, especially with the screws that are coming from bottom to up. And so we're able to do that pretty seamlessly. We need to get better. We need to get more efficient. This did take us about 8 hours, but again, pretty bloodless surgery for the amount of levels that we were able to do. So one of the problems that we talked about is the problem of stereotaxy. How do you get a preoperative image to match with your intraoperative real-life parameters? And that's extremely difficult in MIS surgery, where unlike brain surgery or other types of surgery, you have good surface markings that you can do. And so we're working with other companies to look at computer vision to help solve this problem of stereotaxy. Because if we can go from preoperative imaging to intraoperative imaging seamlessly, then that will make the adaptation of robotics even better. So if we look again of our ideal imaging navigation system, we've actually also developed another thing that we're using here at Duke, and this is what we call computer assistant instrument navigation. So here we actually put the fiducials on the regular C-arm, and we use an infrared tracker. And we publish papers then now showing that when we're putting in pedicle screws, we can be 70% faster and 60% less radiation. And you can also see that we've taken out a lot of the variation in surgery, which is really important. Here is an example. So this is actually a prone X-lift. You can see here that we've made software that allows us, when we're orthogonal, to then be able to put in the intrabody, and we can see the cob going in both dimensions in real time. Some of the most exciting things that we're doing also is when we're putting in pedicle screws, now we can navigate 2 pedicle screws at one time. Why do we limit ourselves to just 1 pedicle screw at one time? Now I can see with the resident or fellow what they're doing at the same time simultaneously. So that's even now cut my OR time even, before it was 70%, now we've taken that even 70% faster. How about accuracy? So we looked at that and we compared it to my robotics cases, and it's about the same. So right now, man is almost to machine, but we have to realize that at some point, the machine is going to be faster and probably more accurate than man. So, right now we're at this area here, and it'll be very interesting to see what happens in the near future when it comes to robotics. So just to conclude here, I think that robotic spine surgery, especially for minimally invasive applications, will be very important. It allows you to, plan these things pre-operatively and do them safely. And as we get better, more efficiently, I think in terms of future directions, we really want to look at intelligent decompression. And as I showed you with the 2 pedicle screws coming in at the same time, why do we right now only have 1 effector on the robots? Why can't we have 1 or 2? I think the human mind will only be able to look at 2, maybe 4 at one time. But people are working at that. And I think that looking at more versatile end effectors to allow you to do decompressions, to allow you to do osteotomies will be very important in the future. So I think we shouldn't take it as a man versus machine, but we should really look at the machines as our helpers in trying to solve these problems of spine surgery. And so with that, I'd like to conclude and thank the committee so much for inviting me to give this talk.
Thank you so much, Dr. Muhammad.
Thank you so much. It was really an interesting presentation. So, Muhammad, you have mentioned it, but navigation systems are very good, but what's the main advantage of using robotics? What's the we use navigation. We are not similar with the robotic surgeries. So what can you say that? How do you feel yourself when you don't have this system? You're similar now using in your daily practice, but how do you feel yourself when you don't have these instruments? How can you do the surgeries when you're using this instruments?
So I think you have two questions. Number one question is, you know, what's the difference between robotics and navigation? So, you know, when you're using navigation, you're still using your own hand-to-eye motion. So if you're using navigation and you find a trajectory that you want to do, you're still having to place it. And, you know, we all have our own, you know, problems, you know, whether we have a tremor, whether we have, you know, and so on. So you're only going to be as good as your hand-to-eye coordination. The robot kind of takes that away from you. So you set the trajectory, it puts you into that trajectory, and then you just put in the screw. So there's not as much movement. So now, especially, you know, let's say you're trying to put in the pedicle screws in the lateral cases, those are very difficult to do where you have to hold still, put in, you know, the pedicle probe, then put in the screw. The robot kind of takes that away from you. And so I think that's where, you know, the advantages are. Now, I think you're coming up to a very important, the next question is a really important one, right? What happens when the robot stops working or that the robot is off? And this is something that I find myself, I'm an advantage because I was trained by very good open surgeons. So, you know, if something is not making sense, I know that it's not making sense and I stop. But for the younger generation who may only be trained in navigation or robotics, that's going to be a big problem because they may not realize, you know, what the robot is telling them is not correct. You know, just to, you know, sometimes the navigation doesn't work or the robot doesn't work. I'm actually happy because then I can go back to how I was trained. But for the younger generation who may not have that advantage, that's something that we really have to think about. And I think that there's no substitute for good anatomical knowledge and good training. I always have the C-arm in the field, no matter what I'm using, because, you know, as I tell my residents, you know, an image doesn't lie. So if it doesn't make sense, don't do it. But those are really important questions. You know, we're training residents now. I'm almost doing no open surgeries. And so I think that's the lost art that we have to think about.
Yeah.
So may I ask you, Dr. Muhammad, so do you see yourself in 20 years when the robotic technology is so advanced, so this is not a problem anymore? The robot is always reliable, the robot is always right. So do you see yourself just sitting in your office and telling your robot what to do in 20 years? Maybe sooner, I don't know.
I think that's definitely going to be something that we see where, you know, if you look at, you know, our colleagues in urology and general surgery and so on, you know, they're doing their surgeries, you know, right beside the patient, but they're not actually touching the patient. You know, and so I think that in the future, there's definitely going to be a similar situation.
Okay, so we will be office surgeons.
I absolutely think that if you think that that's not going to happen, you know, we have to think about, you know, how we're going to do that and how we're going to police ourselves. And it's going to be, you know, you can't lose the understanding of who you're going to operate and what you're going to operate on. But definitely, you know, the days of big open surgeries and so on, they will have some role, but their role is going to be minimized in the future.
I think I will agree with you. Thank you so much. It was very interesting presentation, and also it had a very good philosophical flavor that we should not be fighting with the machine, but we have to try to befriend them and to use them in our advantage. It was great.
Absolutely. Thank you.
Nikolai, Naja Al-Abadi is with us, and he wants to say something and ask a question.
Please, Najib. Yeah, we will be very happy to hear it.
Hi, good morning, good evening, good, I don't know what's the time in each country. So I'm very happy to see that these two committees are doing the same webinar. Congratulations for Salman and Thad, of course. And my question is about, you know, in the low and middle income countries where there is no, of course, neuro navigation, no robotic, and in my experience, and most of Moroccan neurosurgeons in the north of Africa, in Africa, they are doing, of course, spine, a lot of spine without all these technologies and these tools. And especially, for example, where the neuronavigation, in my opinion, when we have, you know, enough experience, we don't really need it. It's not really mandatory to have neuronavigation to go to the you know, to put the screw in the right position. This is my opinion, and I'm completely convinced by that. Maybe for the you know, the young people, the beginner, use it, but as a simulation the first, and then I hope that they will continue to do it without really neuronavigation. This maybe neuronavigation is very important in some cases when there is some scoliosis or some deformity, and it's a little bit more difficult to have to put the screw in the same position. And especially second question or comment, maybe more comment than question, is about robotic. Really, in your experience, do you think that really robotic give you more confidence in your experience in daily practice, or just for me till now I am thinking it's more tool, modern tool that we are using, and till now I don't think it's very mandatory to use it. What do you think, Professor Mohammed?
Thank you, Doctora. So, you know, I think your comments are really good ones. I think that, you know, for the average case, I would agree that, you know, you don't need to have navigation or robotics. And I think that, you know, learning to do things with your hand and knowing the anatomy, there's no substitute for that. So actually, I teach my residents. So if we're doing a percutaneous case, I said to teach them, you know, find the starting point, what you think the starting point is, and then look at the navigation or look at the robot and see, you know, do they compare? And then if they don't compare, then you have to think, were you wrong or the robot wrong? Usually, if it's me, I would be more confident myself. You know, but if it's a beginner, then they have to start, you know, learning, you know, what the right thing is. In terms of, you know, the current iteration of robots, I don't think it's mandatory. None of these things are mandatory. I do think that they do help in certain situations. You know, so like I showed you when we're doing lateral surgery, I think that's very difficult for the surgeon to do on their own. But you know, these are really important things that we need to think about, especially when we're training our newer residents. You know, not to lose the art of, you know, anatomy and basic surgical knowledge.
Thank you. Maybe Dr. Derkawi will give us his experience, because he's in the department, one of the masters in the spine surgeon now. He's dedicated not only for the surgery, spine surgery, but mostly not spine surgery. So please, can you give us your opinion?
Thank you, Madam, for your word, and I'm still learning. The art of spine surgery is just a large field of accuracy, more than that. And I think that spine surgery, and thank you, Professor Mohammed Al-Bari, for your talk. It's a matter of accuracy and safety, and this is why we use robotics. Just I like talking about history. I will like to hear the answer of Professor Yazarjil when he starts using microscope, and someone come and tell him, if the microscope turn off, what is your options? This is my first, I think in 20 years or 30 years, we will not have this discussion. Maybe we will have more than one robot in the same OR. So this it's not so easy for low and middle income countries for sure, but I think that it will be more democratic to have the robot, and we will not call it a robot anymore in 20 years. Or maybe we will call it just assistant, surgical assistant tool or surgical arm or something like that. And my second reflection about this is I think we are looking for more accuracy and more safety, and if we have a tool that gives you this option, so it's just it's just mandatory to use if you can use it. But still until now, robots are not that refined with navigation to have this accuracy, and this is why in the US they still ask surgeons to put by themselves screws. So we hope that we're still doing that by ourselves, even if we have the most sophisticated. I don't believe that I can do surgery in office like what to say, Dr. Piv. It's not fun anymore to do this work. So I will move for another thing. But I think it's we need to touch the patient and to deal with difficult cases, even the most simple ones. And the last one is for low and middle income countries. They should know about this, but even C-arm is a luxury for in some countries. Anatomy is so important. Sometimes we need to do surgery even with the less available tools, just to help a patient in somewhere in but it's just we need to have this balance, because we can spend a lot of money in some places around the world to offer the most options for few people and for large number of human beings. They even have this surgeon that can do spine surgery in their country. So as a WFNS, we need to have this balance between and push to have both neurosurgeon and most sophisticated techniques for everyone around the world. Is my opinion.
Great comment, fact, and this is really true, and I really appreciate your words. I think now we will progress further. I can see that Mirza Poskic from Germany has raised his hand, and I think we'll give him a chance to comment and also maybe to continue as his talk is really complementary to what's been said so far. Mirza?
Thank you, Nikolai. I just want to compliment Dr. Muhammad for the great presentation on robotics in spine surgery. And I wanted to ask only three smaller questions before we go further. One of the biggest problems which most people who do robotic surgery have is the robot abandonment, technical issues, installation issues. They can really make your life horrible in a OR. So I wanted to ask, do you have at your institution a technical team, a technical persons who take care of the robot? Because at our institution, without that team, we would be totally lost, because, you know, combination of doctors and technology is not always the best one. That would be the first question. The second one would be your opinion on quality control in robotic spine surgery. You know, most of the papers concentrate on screw per time or deviation of the actual screw which you place from the pre-planned screw trajectory. So what's your opinion on how important are actually these two parameters when you have the quality control of your robotic surgery? And the first question is that, as of a technical nature, where do you put the reference array? You did a very nice talk on the percutaneous TLIF implantation that was very impressive and innovative. and on the instrument tracking, but the reference array position, do you do several scans during surgery? Do you reposition the reference array if it is too far away from the place where you want to put the screws, for example, for longer constructs? And thank you once again, it was really impressive.
Dr. Mirza, thank you so much for your question. So I'll try to do each one separately. So the first one was about the technical issues. I think it's critical to have a technical team there. I think one of the problems that we're finding, and I'm going to be honest with you, I'm doing now awake spine fusion, and time is of great essence. I cannot be waiting for the robot. The robot now is so slow for it to come in, and then, and the patient is under spinal anesthesia, and I'm under a timing. I have to be done in 3 hours, and so, having a technical team there is very important. We're looking actually at our data now to look at my awake spine fusion robotics versus the instrument tracking. Right now with the instrument tracking, I can put two, as I showed you, I can put 2 pedicle screws at the same time, which cuts my time way down. So I can do now, an awake 1-level T-lift in 40 minutes. And so that's, when I talked to the robotics people, I said, that's what now, if you have a poor surgeon who's taking 5 hours to put in the screws, the robot is going to beat them. But if you have a good surgeon who's doing the things in 40 minutes, right, that's what you have to beat. And so I think that's, something that we're, I think the robot's still not there. As Dr. Fahad said, we have to look at history. So if for us, cranial surgeons, stealth, used to be something really, really slow. They used to actually say stealth meant surgery time increased by at least 3 hours. But now, stealth has become, kind of standard of care when you're doing a craniotomy. And so we have to kind of understand that things are going to develop quickly. I think that goes to your next question about quality control. What quality ways are we going to make sure that we, do the things correctly? Because, there already, I heard about, lawsuits of, misplaced screws. And can the surgeon say, well, the robot told me to put it there? No, the surgeon ultimately is responsible. So, those are things that, we have to work on for the quality control. In terms of the reference array, so that problem of stereotaxy is a big problem. And so if you have something in the PSIS and you're going to T10, that distance may be too large. And as you put in more and more instrumentation, all of that will be changed. And so those are things that you have to take care of. And so there's different ways to do that. Some of the ways that we've done that is, instead of putting in the intrabody, putting a wire there just to hold your spot, and then putting in all the different wires and then doing the intrabodies separately. But those are really, really important questions that you have to understand the limitations of the robotics or the navigation system that you're working with.
Thank you.
Great comments, and I think it's a good discussion happening. But I think we also have to go with the time. Mirza, I think probably it's time for you to start with your presentation.
Yes. Okay. So I would like to thank Nikolai and Onur and both committees for this kind invitation for today's talk in this webinar, Innovations in Spine Surgery. My talk is going to be on use of augmented reality in spine surgery. And I want to thank my boss, my mentor, and the head of our department, Professor Rimsky, for helping me out in making this presentation. He's one of the world leading experts when it comes to augmented reality, and he gave me some of his slides in order to make this a better experience for all of us. I work in Marburg in the department of Neurosurgery in Germany, and we are actually the first department who published a case series on robotics, on robotics, of course, but on augmented reality in spine surgery. We use an intraoperative CT, and intraoperative imaging-based registration does not need patient and user interaction. It can be automated, which offers the possibility of reduced registration errors. And ICT and AR applications include tumor, non-tumors, degenerative trauma, inflammation, and deformity, and rheumatoid arthritis lesion, and can be used for anterior, posterior, and lateral approaches. We have a low dose protocols, which allow for significant reduction of the effective doses so that the whole experience is also good for patients in terms of the reduction of the total radiation doses. Because of course, if you do any kind of spine surgery involving fluoroscopy, you have a certain radiation of the patient, and with the intraoperative CT with low effective doses, you can even come to lower cutoffs than with the use of fluoroscopy. Our intraoperative workflow is here depicted in a scheme. We usually do the preoperative imaging with image processing, intraoperative registration scanning, automatic patient registration, nonlinear registration of the plan, and we can do several ICTs in order to control if our operative goal was achieved. Augmented reality neuronavigation, that is a significant advances that provides a real-time updated three-dimensional model of anatomical details, which is overlaid on the real surgical field. And it enhances the surgeon's perception of the surgical environment. We use the microscope-based augmented reality, and it overlays 3D projections derived from preoperative images into the bilateral eyepieces of the binocular optics of the operating microscope. So in order to understand what augmented reality is, there is this very good scheme. So you have real environment, which is direct view of reality. Augmented reality would be virtual objects overlaid in a real world environment. Augmented virtuality are real objects projected and controlled in a virtual world. And virtual reality is the next step. It's immersion in a fully digital environment. So reflex vizier, these are the so-called ancient beginnings of the augmented reality from before the World War II. It was developed in Germany on the fighter jets. And this was actually the augmented reality evolved from the airplane technologies to the medicine. And it was used in order to have a virtual 3D image of an enemy plane, which you can then shoot off with your own one. And this is how it looks today in Airbus. This is the control panel of the Airbus. For example, in airjet fighters B737 and F-16, in order how you see the 3D projection of the other objects around the plane and of the surrounding. In head-mounted three-dimensional display was invented in 1968. It was first published in 1968, and this would be the beginnings of the head-mounted displays, which we use today for augmented reality. It is one of the possible applications of it. And this is the most developed and the most modern Joint Strike Fighter F-35 head-mounted display, which allows you to look 360 degrees in your surrounding and to see the overlaid three-dimensional objects from the surroundings. So you don't need to look at the control panel or in our case into the operative microscope, but you have a head-up display which allows you to revolve around and see all the object in three-dimensional way, like this small video is showing. So these were the beginnings of augmented reality, and it found its way kind of from the Air Force, especially from the military Air Force, into the medicine and into the operative microscope. So these are the possible applications of augmented reality. You can use it on your monitors, the so-called monitor augmented reality, with head-mounted devices, or microscope-based augmented reality, which uses head-up displays on the operative microscope itself. So head-mounted display for intraoperative viewing of neuroimaging was first published in the year 1995 by Barnett. It was the cutting-edge technology back then, but now it has become more or less a standard in many neurosurgical departments. So these are some intraoperative photos, not from our department, because we use exclusively microscope-based augmented reality. And this is really a preference of a surgeon if he finds it good to wear this head-mounted device or not. Some people swear on it. We are not very convinced that this is the way to go, but we still prefer the microscopes, which give you actually a 3D depth information, which you are used to as an operating neurosurgeon, with addition of augmented reality. So computer-assisted stereotactic laser microsurgery for treatment of intracranial neoplasms and frame stereotactic integration of ICT images and the operating microscope derived from the 80s. And in the 80s, combined with this Air Force technology, it came to the merging of both of these concepts into the neuronavigation ICT-based augmented reality. These are the publications from last years, which show the possible applications of augmented reality and the possible uses and the modalities of use. For example, with the use of head-mounted display in order to put AR-navigated pedicle screws in with these glasses or with head-up displays. With several other modalities where you have, for example, in the lower part of the photo, you have a barcode on the head of the pedicle screw from which your HUD reads the future position of the pedicle screw. And there are several operative videos which you can find. Some of them are also open access, which show the triangle which Professor Mohammed was talking about. You can show it, you can see it here on the left side, which is then shown for the maximal safe implantation of the cage. You can now practically and virtually segment any structure, any triangle, and any operative corridor and transfer it to your image on the operative microscope, and in that way perform a more safer surgery for your patient. This is from our department, a model of the lumbar spine, which then underwent an intraoperative imaging and processing with a software. And this is now the view which you get with your operative microscope when you look at the model of the spine, and he can totally isolate the vertebra which you need, isolate the nerves, the discs, and all structures separately. And of course, in any position of the operative microscope. So since when we use augmented reality, usually perform the intraoperative CT imaging before, we need to fuse these images with the images which are performed before the surgery. So with intraoperative with the MRI or with the CT, which was performed prior to surgery. And this is a very important and critical step if you want to have a safe and maximally safe use of the augmented reality. So you have to have high accuracy of the initial patient registration, so a very accurate initial scan and a very accurate fusion of the part of the spine you are doing a surgery on. Otherwise, your augmented reality will not show the structures in the position in which they actually are, but they are going to show a certain offset, and that offset can lead you to make wrong operative moves, so to say. So here you see on the left side rigid, and on the right side the elastic fusion of the cervical spine. That is the most movable part of the spine, and it is very dependent on the position of the patient. How the spine moves. It has a lot of movement in it, so you need to invest a lot of time, effort, and technical skills in order to fuse correctly two parts of the cervical or upper thoracic spine. And here you also see the one further technical issue is when you fuse the preoperative MRI with the intraoperative CT, because your intraoperative guidance in this case is the actual intraoperative MRI, but the segmented structure and the segmented objects come from the preoperative MRI. So when you fuse the both, then you can have the so-called truth through the binoculars of your operative microscope. So we use modern operative microscopes with integrated head-up displays in conjunction with navigation system, and they allow for visualization of augmented reality of three-dimensional colored objects in real time. For AR support, these HUDs or head-up displays are used, and the microscope is tracked in space using a registration array which is attached to the microscope. To check the AR calibration, you put the center of the microscope about the central divot of the registration array as shown on this photo, and such that the alignment of the AR visualization of the array and the optical outline can be checked and adjusted if necessary. One good thing about this is that you can visualize all the object as semi-transparent, solid, or in an outline mode, and you can switch off the objects if you have the overcrowding of the surgical field. I will show two short operative videos which will then make this, I think, more clear. This would be our intraoperative setting. Here you see a patient who is undergoing a spine surgery in a prone position with a reference array which is attached on the spinal process. And you see over there the registration, the camera, which is then pointing at the reference array on the patient and at the reference array on the intraoperative microscope. How to check the accuracy of augmented reality and the accuracy of the microscope? Well, we usually put fiducials around the skin incision, and you can center the zoom of the microscope or the focus of the microscope to the fiducial and then check on the display if you are exactly at that projected position. One further way to adjust or to check the navigation accuracy is not only on the fiducials, but on the tumor outline, if you're doing a tumor resection, of outline on the vertebra, or on outline of the implanted screws or implanted expandable cage, like in this figure. This is from our publication of application of CT and augmented reality for lateral approaches of the spine. For example, you see here one expandable cervical cage, and we put the pointer on the cage and check if the navigation accuracy has moved. So the updated intraoperative imaging gives you then more and more security throughout the procedure. I've already talked on reduction of effective dose. This is from our publication, effective doses for augmented reality in spine, where we see that using the low dose protocols, we have managed to achieve a very low radiation exposure for our patients. This is now operative video. I hope it will work. This is a resection of a calcified herniated disc, T78 via left retropleural approach. This patient received the surgery in an external institution, but via posterior approach, we had a calcified herniated disc. And we have resected this herniated disc via lateral approach. So this is the position of the surgeon at the beginning of the resection. These yellow outlines are outlines of the vertebrae, TH7 and 8, and in blue you see here the outline of the herniated disc. And throughout the surgery, this is the calibration of the microscope with the reference array. The reference array is attached, in this case, onto the pelvis, the spina iliaca, and now you see practically through your microscope where the herniated disc is. You see where the vertebrae are, and this is the blue outline of the segmented herniated disc. So in case of calcified disc, you cannot know for sure where what is. You know, you see a bulk of bone which you approach from lateral side. It's an approach that many neurosurgeons are not familiar with, and this is especially for young surgeons which have less experience, a very good method in order to increase safety during the surgery. Of course, as previously said, big problem is if we grow generation of surgeons which are not confident and do not know how to operate in a classical way using only anatomy knowledge. But for these cases, I think even for experienced surgeons, it can pose a challenge to resect a large herniated disc via lateral approach without damaging the important neurovascular structures. And in this case, we have used this kind of navigation and augmented reality. This is once more in a 3D outline. This is where the disc was, the herniated disc, and it is now totally removed. And you see also that this is the disk space, and disk space actually has here 100% corroboration with the intraoperative images. So this shows us that it is very, very accurate. So this would be the same patient, and you see here the preoperative imaging and the intraoperative imaging CT, which shows that the herniated disc is completely removed. You can use the augmented reality not only for anterior, but also for not only for lateral, but of course for anterior and posterior approaches. These are the examples of resection of recurrent herniated disc, and for the corpectomy in the cervical spine, and of course for the use in the intradural tumor surgery. I think first paper on the use of augmented reality in intradural tumor surgery was from our department. This is one hemangioblastoma in the cervical spine, or the craniocervical junction, where you see in the photo on the upper right side the contours of the adjacent vascular structures of the tumor and of the cervical spine, and the post-operative control. In the intradural spinal tumor surgery, overall use of augmented reality was 5 to 92 minutes. That means that we did not use it always the whole time throughout the surgery, but sometimes also only as an accuracy check. Compared to microscope usage, we used augmented reality from 9 to 97.9% of the time, and it could be switched on and switched on 2 to 70 times per surgical case. This is also one operative video, also a lateral approach. This is a total resection of the first lumbar vertebra in one osteoclastoma of the lumbar spine. So the patient received previously a dorsal stabilization with pedicle screws. Now we see isolated the one vertebra in which the tumor is found. Osteoclastoma is a benign tumor, but it needs to be resected totally in order not to recur and not to make further problems. And here you see superimposed image of the vertebrae, which were where the pedicle screws were placed with the exact position of pedicle screws. So in this example, you see how helpful it can be, and in order to get the proper intraoperative orientation throughout the spine surgery. And of course, you can switch on and switch off the augmented reality anytime you want, so you don't have this overcrowding of the different objects in your operative microscope. But you have, even if you switch off the head-up display of your microscope, you still have the total control over the objects and what is on the display, which is in the same OR just next to you. And this is the placement of the expandable cage at the end of the surgery. So this would be the reconstruction of the control intraoperative CT, which then shows you can also put different objects into the AR mode and visualize them through a microscope. So the key for a good use of augmented reality is to have the high navigation accuracy, and the highest navigation accuracy you have if you have the automatic registration, and the automatic registration is best achieved by the intraoperative imaging. You can do re-registration during the procedure if you think that your accuracy is not correct. You can do the immediate intraoperative quality control with intraoperative CT, and you have the objective evaluation of the intraoperative situation. It increases comfort for the surgeon in reoperations. It's a good tool for resident education, and it gives estimation of tumor extent even when registration accuracy is compromised. That means even if your accuracy is not 100% there, you still have before your eyes the estimation of the growth of the size of the tumor, and you can then do your resection to the end accordingly. And since all those protocols are implemented, repeated scanning can be performed with reasonable radiation exposure, particularly if the scan length is restricted to the area of interest. So there are some departments which scan total spine before the procedure and during the procedure, but we choose always to do only the part of the spine which we are performing surgery on in order to reduce the radiation exposure. So what is next? It is the mixed reality using augmented reality and virtual reality. And this is how we expect that the ORs are going to look in the future, where you will have the entire OR in some kind of augmented reality, mixed and virtual reality setting. Future is to perform registration and intraoperative imaging and the surgery and the postoperative control. So everything you need in one OR, this future is already coming to in the robotics and neurosurgery with the so-called robotic suits. And we are expecting that it will also come into that will come to development to augmented reality and virtual reality suits in the future, and probably with the combination of the both. Okay, thank you very much.
Mirza, thank you so much for this
Thank you.
good presentation. So you have CT, you have navigation, you have augmented reality. So you don't need any surgeon now.
Well,
is there any question?
well, that's how it looks. But I have experience with use of all of this technology when I was a resident, PGY 3 or 4 or 5, and now several years afterwards. And it's, you know, nothing can replace the experience in OR. Nothing can replace endless night shifts, cadaver courses, anatomy courses, anatomy knowledge. This is a very good adjunction and addition when you already know how to perform a certain surgery. You know, and it's maybe good when you are in a level 2 or level 3 of becoming a master at some surgery, you know, but it is not going to help someone who never performed a herniated disc surgery or ACDF. I don't think that augmented reality robot or whatsoever is going to help him at his first stage. But I think it can help you to get from stage 3 to stage 5 or from stage 5 to stage 7 to come there more quicker than before.
So Mirza, everyone is shocked. There is no question.
I'm just going to ask this, Mirza, you know, we've been talking about what is the future. So you think a robot will replace us at some stage or replace majority of the work? Like, you know, for example, assistants are already been replaced by robots, especially when, you know, there's a shortage of young doctors. So you think at some stage there'll be shortage of neurosurgeons or spine surgeons, and then we will have a robot doing some of those simple stuff?
You know, I would be very happy if I would have my double robot who does the surgeries while I'm on vacation. That would that would make me very happy. But I don't think that we will ever come to a point where you have just a Terminator or Robocop-like robot who does everything and the surgeons are not needed. I think that at this point, for the next 30 to 50 years, we will have still cobots, and cobots can't work without us. And I know that there is a University of Pittsburgh is now doing a big research on developing a robot assistant, which is kind of following what the surgeon is doing and doing the assistant. So that would make residents not needed anymore, and that would in the next 20 to 30 years make also less neurosurgeons. But I'm not sure, you know, there are also a lot of media There is also a lot of media coverage which is negative towards robotic surgery. Every 2 or 3 months you read that somebody died because the robot made mistake and the surgeon left the OR. There was like several months ago that for cardiac surgery, I think, a case. So I think that the opposition to the use of robots is as big as the people who are trying to make money out of it and to put it in the daily practice. So I don't think that neurosurgeons are ever going to be replaced.
Mirza, when did you phone your bank last?
my bank?
Yes.
2 days ago.
Did you speak to a human being, or it was an automated machine that is speaking to you? Because that's what's happening with me. It's very unlikely if I call my bank, I will speak to a human being. It's all machines there, all computers. So I was not expecting this to happen this soon, but it happened. So I think we're going to see pretty soon that there will be more robots, there will be more augmented reality. It's going to be sooner than we expect, I think.
There are already softwares where you put the spine of the patient and the software gives you a proposition how many levels you need to fuse and to put the cage or not put the cage. I think one negative development would be that the neurosurgeons are going to start to shut off their brains probably with the time and more rely on some kind of algorithms and automated algorithms, and that is wrong.
I think the other thing, Mirza, you might have in 2 years is that, robot doing skin suturing at least. So that, because then that saves time and whatever, if you have a robot, then, at least they can do simple stuff and you can move on and think about other things in the meantime.
Yes, that would be certainly an advance.
So, Nikolai,
okay.
I think we can pass to the other talk.
Yes, I think it's time for the third talk. It's very interesting discussions we had today, following very interesting topics and presentations. And thank you so much for the presenters. Unfortunately, the third presenter, Andreas Dimitriadis, he will not be with us, but his lecture will be with us because he kindly sent that to us. Andreas is the current president of ENS, and due to, he emailed us that he has some emergency and he is not possible to be with us. But we will be still happy to hear his presentation. So Imad, please play the presentation.
Colleagues and dear friends, thank you very much for the invitation to participate in this webinar. Special thanks to the chairman of the two organizing committees, Salman Sharif from the Spine Committee of the World Federation of Neurosurgical Societies, as well as Fahd Derkawi, who is the chair of the Young Neurosurgeons Award Committee. And this is in an effort to encourage people to apply for this award, which will hopefully be presented at the next World Federation Congress in Cape Town in the autumn of 2023. The topic I have is research wastage in spinal randomized controlled trials, and I have no disclosures. I'm very grateful also to the co-presenters for creating this useful atmosphere today. We know from previous data that randomized controlled trials are very expensive to organize and to run. They range in an average cost from as little as $4 million up to $20 million per trial. And we also know from previous work that I'm showing there on the bottom right in neurosurgery, but also in other fields, that some trials are not published or not finished, and indeed sometimes finished but not published. And avoiding the dissemination of such data can distort the landscape of evidence, and it can interfere with the rationale behind clinical decisions, development of guidelines, and compromise patient safety. It is therefore a major source of waste in clinical research to have randomized controlled trials discontinued or not published. And the rates we identified in a previous exercise with some colleagues here in my department is that the discontinuation rate of RCTs in neurosurgery was just over 1/4, and the non-publication rate was almost 1/3. So on this occasion, we decided to tackle a slightly different question, which is the question, what is the rate of randomized controlled trial discontinuation and non-publication in the field of spinal disease per se? And we looked at this over an 8-year period from the beginning of 2013 to the end of 2020 inclusive. The methodology was fairly straightforward. We generated a list of randomized controlled trials in the field of spine or spinal diseases that were registered on the Clinical Trial Gov's database. We did not include research studies that were not randomized controlled trials and that were not directly related to spinal conditions. And therefore, we created a small database specific to this project and looked at parameters like the progress status of the trial, the source of funding, whether it was industry or academic or other, the number of centers, whether it was a single center study or a multi-center study, the type of intervention, in other words, whether it was pharmacological or surgical or other, the affiliation of the PI, whether it was published or not, where it was conducted, why it was discontinued, if it was, when it was published, and of course we looked at subtopics. At the beginning, we had a lot of positive hits in our search, almost 9,000, which is obviously filtered down quite a lot after relevant exclusions, and we were left with 112 trials, which is quite a significant number after this filtering exercise. Let's look at the subtopics within spine of what the trials were working on. The first 3 have the vast majority of trials, and that's back pain at 42% plus, pain management after an operation, which involves obviously anesthetic and pain management colleagues at just over 1/5, and ankylosing spondylitis from rheumatology colleagues, again, at nearly 1/5. Other topics of specific interest to us, like spinal cord injury, degenerative spine disease, radiculopathy, spinal tumors, congenital diseases, or inflammatory diseases, mixed back and neck pain populations, infection and neck pain on its own, all of those were small individually in how much they comprised of the big proportion of the studies included. The key findings are the 2 here. Nearly 1/4 of the clinical trials in spine were discontinued. They were stopped. And amongst the trials that were actually finished, the non-publication rate was high at 35%. The reasons for discontinuation were provided. Slow recruitment was identified as the biggest problem, as we can see in the bar charts on the left. Other reasons, such as logistics or unavailability of funding or failure to achieve desired endpoints, or principal investigative factors such as migration to another department, etc., all were 12%. COVID, towards the end of the study period, quickly ramped up 8%. Those are trials that may still continue. And a small number, 4%, failed to obtain ethical approval. If we were to compare a range of parameters between the studies that were completed or discontinued, we can look here 4 categories of topic, intervention type, funding status, and number of centers. I don't want to go through this in too much detail, but for example, if we look at the star, where there is the funding status, the difference between industry and non-industry funded trials that were discontinued was not statistically significant. And that's useful to know because there is this impression or perhaps suspicion amongst medics that industry-funded trials are more likely not to be published, but this was not the finding of our work. We also looked at whether multi-center or single-center studies are more likely to be discontinued, and you can see at the bottom that 67% of single-center studies were discontinued, which is double to those which were multi-center. If we then look at the comparison of published and unpublished trials based on similar groups of parameters, again, the topic, the intervention type, the funding status, and the number of centers, we can see again that there is no significant difference in industry versus non-industry funding. Whereas the multi-center versus single-center division has actually come closer. Now, there's a lot of questions that are born with information through this sort of exercise, but we have to acknowledge a couple of limitations. First one is that we use the clinicaltrials.gov database, and this search can be broadened to include additional trials registered in potentially other registries such as alltrials.net and edura-CT, although to be fair, clinicaltrials.gov is by far the most comprehensive one. Secondly, the search for publication results was through PubMed and Google Scholar. However, there are possibilities that certain trials which were registered in one particular way may have been published under a different title and so on, although we did our best to make sure this was not missed. And finally, this study only looked at the landscape of trials at the single point in time, which of course may be different if we repeat the exercise a few months or a couple of years later. But again, this is something that will always be a limitation. In terms of take-home messages, I think this is very important to realize that nearly a quarter of all trials in the spinal disorders during this study period were discontinued, in other words, stopped. Half of the trials altogether were unpublished, and overall, there was over a third of trials that were actually completed but not published. These rates remain worrisome from a financial perspective, but also from an ethical perspective. Underreporting and non-publication both adversely affect efforts in evidence synthesis and can compromise clinical guideline development. And effectively, greater transparency is needed to better understand the reasons behind why randomized controlled trials are discontinued and or not published in spinal disease research. Once we create an environment of better transparency, hopefully this will minimize research wastage, and also it will protect research integrity. I'd like to thank you for your attention and invite you to join the EANS Congress in Belgrade from the 16th to the 20th of October, where we'll have hopefully a fantastic scientific and social interaction. Thank you for your attention.
Okay, thanks to Andreas for the interesting presentation and for the, I think, interesting food for thoughts. I don't know if somebody wants to comment about that. Someone, have you had any discontinued trials, and why did you discontinue, and why did you not publish if you had? Mirza?
I think we know of many people who had RCTs and they were discontinued either for financial reasons or that somebody who was the main pillar behind the study moved from there. or lack of, as Dimitris pointed out, lack of recruitment. And I think that is because the expectations are completely different. What really happens in reality is completely different. So I think it depends on how passionate the person is who's doing the study, and what about the co-workers, what are they like, and your affiliated institutions, what kind of incentives they have. So I think many factors play a role, and clearly not one thing is the factor here. Owner, what do you think?
So there are lots of reasons. I think the main problem is the financial problems. So it was a good presentation. And any questions from the audiences?
I just have a comment. It's about waste of resources in many countries, and I think in the whole world we have a problem of resources, and this create a lot of tension around the world, and in our field as neurosurgeon and in research. So it's matter of the resources belong to humanity, not just to one country. So we know that today that the resources are limited, and we are it's mandatory to manage them, these resources with wisdom. And if the resources are invested to marketing and to financial income, it will be like that. Like what had said Mr. Salman, when industry don't want to have the real results appears on the PubMed, they will not then publish like that. And it's pity, because someone in Africa, in Asia, on the Latin America, who don't have these resources will conduct again the same study and waste limited resources to reach this result. It's not there is no impact on human being health. So we should pay attention to that as doctors and as researchers, to share our knowledge, and not let some other person to hide the truth. Sometimes it's not a good thing. And for what was said, financial problems, there is all financial problems to invest in research in many countries. I'm talking about Africa. So it's just less than 0.1% of all the money that a country have is invested in research, not like the high income countries. So it's a big deal for us to not waste this money. If we want to have a CT scan or navigation, we should manage to invest correctly our limited money. Thank you.
Great. Mirza, do you want to comment?
I know only about a lot of spine studies which are discontinued because the endpoints of the study were reached before the planned period of time. For example, there is the study from 2015 which was published in Lancet, decompressive surgery plus radiotherapy versus radiotherapy alone for spinal metastasis. That was a study which was planned to go on for 5 years, but after 12 or 13 months, it was clear that vast majority of patients profit more from decompression plus radiotherapy versus radiotherapy, and it was then ended because that was one of the endpoints of the study. When you see that one method which you wanted to examine against the other method is a lot better. So I know those kinds of discontinuation, as Onur said, financial problems. There are some studies which for example, for interspinous devices, which I hope nobody uses anymore, but for when the intraspinous devices came to market several years ago, there were several studies which were started very optimistic, which compared the compression against spacers. And to my knowledge, at least in Germany, most of these studies were never finished because the clinical experience has shown that these devices are I would not say a scam, but they were actually they didn't show to be as good as they were commercialized.
Yeah, but these are always when the study is discontinued is before it for a reason that is showing that definitely there is one of the branches is way better than the other one. Then this is a good thing, and this is
yes.
I wouldn't say this is a wastage of resources, but maybe the other way around, which is a good thing.
Yes.
I liked what FACT said about the unequal spread of the resources, and maybe this is also a problem that we have to talk more about, and we have to try to overcome in a way that we possibly could, because, for example, let's say trauma, the research for trauma is coming, majority of the research papers are coming from the high income countries, but the landscape of trauma is quite different in high income countries comparing to what is in Pakistan, for example, or what is in India, for example, or what is in Nigeria or somewhere else. So yeah, so maybe this is another topic that, and I think FACT has mentioned this as well, and I think this is important for us to talk and maybe to think what we can do about it. And the committees maybe have to do steps towards this direction.
You're very right. And Nicola, as you know, we, especially in the spine committee, have focused for Africa this year. And for that, we are having a large workshop in Ivory Coast in a couple of weeks' time, followed by, I think we'll be there in Cairns as well, doing a workshop for them, and then in South Africa in 3 months following that. So I think this year we plan to train at least 100 spine surgeons in Africa, at least basic course and advanced course, at least 25 to 30 of them. So we select 25 to 30 of them to make sure that we get there at the end of the year. And the next year, we plan to focus that on Central America, and hopefully we should be able to make some change there. And, you know, it's with all our friends who are present here, all of them are playing a huge part in that. So I'm grateful for that.
Just one information. I want to thank you, Professor Salman, for this and all the committee for this huge effort to develop spine surgery around the world. Just for the awards, Neurosurgeon Awards, the committee will include the impact of research and also the background of the lab where the research was conducted in the selection of the 5 awards during WFNS World Congress in Cape Town. This is, I think, it's like this mandatory to include this equal way of to judge some research. I believe that someone who is conducting research on spinal tumors in sub-Saharan country don't have the same resources as in high-income countries like with lab, like what have Dr. Mirza. So we need to see the background, but also the impacts on the health of our patients. So it's what we thought to do as criteria in for the next awards, the 5 awards, and I encourage everyone here. We have residents or young neurosurgeon under 40 years old, and you, the colleagues and masters of spine surgery, to encourage your neurosurgeon, new neurosurgeon to participate in this work and share their experience. We hope to hear and to learn from all research conducted and not have this wastage of research around the world. Thank you.
Thank you, Fahd. So I think after all these great presentations and great discussions, I will give the word again to Professor Salman Sharif as the president of the Spinal Committee to maybe closing remarks.
I think I'm grateful to Fahd for being present and getting his committee involved here. And I think it's good that we have these collaborations, and we need to do this more often, Fahd. It's good fun to get involved with young guys and teach and learn from them as well. And I'm grateful to all the three speakers. Excellent talks. I think I really enjoyed all the talks. The quality was very good, and I'm sure we learned loads from this. And I'm grateful to our two moderators who are there. So Nikolai, who took over from America in helping with this workshop and with this webinar, and
Owner as well.
Owner, as always, present there. It's wonderful. And I'm sure in future we have more collaborations with young neurosurgeons from all over the world, and continue to do this often. I think end of June we plan to do another webinar. Nicola, you're going to tell us something about that?
Yeah, so as part of the initiative of the Spinal Committee of WFNS, we would like to interact with the local society. So the next society that is going to collaborate with us is the Japanese Spinal Society. So we're planning another webinar at the end of the year as part of the How I Do It session, and it will be on intramedullary tumors. So everybody welcome to join, and it's going to be quality presentation. So please be with us again.
So it's actually end of next month. So at the end of June or end of July, Nicola?
End of June. We're gonna announce this within the next days.
All right, brilliant. So Fahd, again, I'm grateful, and thank you for everybody who's participated. I'd leave it to owner to close.
Salman, Fahad, thank you so much for this organization. Nikolai, Mirza, Mohammed, it was really a brilliant webinar. I hope we will see it as soon as possible. Thank you so much.
Thank you, and great having you all, and all the best, everybody.
Imad, can we get a group photograph, please?
Oh yeah, we should not forget about the photograph.
Again, everybody switch on their videos and just smile. So we have a group photograph.
Bye-bye.
Are we done, Imad? All right, brilliant. So see you guys later. Good to see you, Giovanni.
All the best. Bye.